Good morning, everyone. My name is Lisa Burke, and I'm delighted to be here early in the morning here in Brussels. A beautiful day and a lovely start to the day as well. So why are we here? Well, of course, it's the European Federation of Neurological Associations, EFNA, together with the European Academy of Neurology, EM. So we're going to talk all about the importance of brain health. And we know you care about this deeply as well. Neurological disorders, they impact millions of people around the world, including our friends, our family and neighbours. They range from lesser known disorders to more common issues that we will all have heard of. Alzheimer's, Parkinson's, migraines. I'm a sufferer of migraines, and the list goes on. Neurological disorders are a huge burden. So how can we address this meaningfully, and what actions can we take? And today also marks a very special occasion. It's the first meeting of the renewed MEP Interest Group, Brain Health and Neurological Conditions, developed by the patient advocacy groups, the European Federation of Neurological Associations, EFNA, and the Pain Alliance Europe, PAE, and now an initiative of EFNA. And this gathering is a call to action. The World Health Organization has set the global stage with their intersectoral global action plan on epilepsy and other neurological disorders. But now it's time to go a step further and start building a national brain plan right here in Europe. And you know that we believe Europe can lead the way. So we've got a lineup of experts here with me on the stage, policymakers, and they're going to all shed light and information on this topic. But we want to hear from you as well. You're very welcome to ask questions in the room here. And of course, this conversation is only just beginning. So do get in touch with EFNA, EAN, and other associated organizations. But welcome to the stage to formally open this event, MEP Tomislav Sokol.
Good morning, everybody. Thank you very much for being with us on this, I wouldn't say maybe beautiful Brussels morning, but rather a typical Brussels morning, but at least it's not raining, so that's a good thing. Thank you very much for inviting me to talk about this topic. Since I'm very active in the area of healthcare in the European Parliament, I'm the coordinator of the largest political group, the European People's Party, in the new subcommittee on health, and I've been I'm also the rapporteur of the Parliament on the European Health Data Space, and recently appointed the shadow rapporteur on the reform of the pharmaceutical legislation. So healthcare is something that is really a priority for me and my work in the European Parliament. When I was reading and preparing for this meeting, I learned that around a third of our fellow citizens, around 165 million Europeans, are suffering from brain disorders. I have to say this was a shock for me. I really never understood or never realized that this number is so high. Because when we speak about public health issues in the European Parliament, we usually discuss cancer. So that's the big thing, and you know we have the Europe's Beating Cancer Plan. We had a special committee on beating cancer. COVID-19, I won't get into that, obviously. Also cardiovascular diseases. So we definitely focus on other issues as major public health problems. And I have to say, brain disorders have not really been in the focus of what we do in the European Parliament, to be perfectly honest. And I hope that this renewed, let's say, MEP Interest Group on brain health can really change that. I think this is a good initiative. I think this is a good possibility and a good event to start off with this, to really be much more active on these issues. Because when I speak about the European Parliament and the visibility of certain issues and topics, it really depends on how organized you are and if you can get MEPs to really be involved. And I think to do that, MEP interest groups are a good vehicle. Of course, interest groups are not formal part of the European Parliament, so they are not like committees, formal part of the legislative structure of the Parliament, but they have really been very important in practice on various issues, because they make it possible for us to engage with each other across party lines, because these issues are not really something that should be based and divided along party lines, but also we can bring other stakeholders, the media, and use this to raise awareness and put pressure on the European Commission to do some things. Because as you know, European Parliament cannot make legislative proposals. we can make amendments, etc. once the proposals come in, but the Commission really is the key, because the Commission is the institution which has to set the tone, has to set the pace, and come up with new initiatives for us to work in the European Parliament. So I think that this kind of rebranding of the interest group of brain, mind, and pain is a good thing, and definitely I think that we can use this possibility to raise visibility and awareness of the issue of brain disorders. When we speak about the European Union and health, obviously we know that healthcare is primarily a national competence. We always start with that because that's a fact. Organization and management and financing of healthcare is primarily a national competence. We cannot harmonize national healthcare systems on European level. For instance, whether systems of health insurance, what will be covered by social security and health insurance, what kind of treatments, etc. But I think still we have a lot of both regulatory instruments and financial instruments to really do much more than we can today. And the number of people suffering from brain disorders definitely shows that we need a common European approach, that we need to work together, especially in the areas of research, innovation, and cross-border healthcare, to increase and improve the quality of our healthcare and access to healthcare. One issue that I've been working a lot on in the European Parliament is the issue of health inequalities, and that's definitely one of probably the biggest problem. If I had to single out one problem in the European Union in health, that's inequalities of standard of care, quality of care, access to affordable care, access to innovative medicines. So if you look at the differences across the EU, they are staggering. So if you compare countries like Romania, Bulgaria, even Croatia on one side, or maybe Sweden and the Netherlands on the other, you see enormous differences, and this is something that we have to change. Also, one thing major problem that in general we are facing when discussing healthcare on European level is the question of health workforce. So in the past we have often focused on infrastructure, equipment, etc. But the issue of health workforce is a major problem, especially in some member states like my member state, Eastern Croatia, and the other Eastern countries of Central and Eastern Europe, where we really have had the big emigration, the big brain drain and outflow of quality healthcare professionals. And in the area of brain disorders, I learned that we only have one neurologist per 10,000 patients, which definitely is not enough. So we have this broader general issue of not having enough specialists dealing with this topic, but in addition to that, we have enormous differences across the EU member states, and this is something that we have to change. So what can we do? When we speak, so one thing is, of course, speaking about funding. So when we speak about funding, so we have the EU for Health program, which is obviously talked a lot about. It's 12 times bigger than the previous budgetary health program in the period 2014 to 2020. Now in period 2021 to 2027, we have 5.3 billion euros at our disposal. And in the previous budgetary period, we have 450 million euros. So it's a big improvement. But unfortunately, most of this money is already earmarked. Most of this will go for the new framework for increased preparedness of healthcare systems for future public health crises, pandemics, etc. So not a lot of that will be left for other issues. However, I think we have still other major sources of funding which are not talked about that often. One is the recovery and resilience, so national recovery and resilience programs, which have one of the big priorities is healthcare, investments into healthcare, and member states can really do a lot in terms of investing in both infrastructure, but also a health workforce, better working conditions for doctors, nurses, etc., to really try to put a stop to this brain drain problem. Of course, cohesion policy, the European policy, which is there to decrease the disparities which exist in terms of economic development. Of course, that standards of healthcare provision are very important there, and this has been traditionally the biggest source of funding from EU for healthcare. In the previous budgetary period, 2014 to 2020, around 25 billion euros have been used to fund mostly investments into health infrastructure, but also through European Social Fund, also into workforce. And this is also one major source of funding that we have at our disposal. What is, however, important is that these sources of funding are not just used to build hospitals, buy equipment, etc., but that we can actually measure its impact. so that we can actually measure how much all of these investments have contributed to having better health outcomes across the EU. And there we have a major problem that we really don't know in most of the cases what is the impact of this funding, and we have to do a lot to change this. Of course, apart from the actual treatment and infrastructure and availability of workforce, etc., a very important issue is research. And in research, of course, now healthcare has become more prominent than ever. The New Horizon program, the flagship EU program for investments into research and innovation from public funding, especially basic research, healthcare has become one of the priorities. And I think this is a good thing. This really provides a basis and opens up the possibilities to invest much more into research, into brain disorders, to invest much more than it is now. And I think this is one of the, I'm not an expert on this, but I think that definitely this is one of the under-researched area when speaking about healthcare. So we will have a lot of room for improvement there. And by having this stronger role for healthcare in the New Horizon, this can really be used a lot to invest into brain research much more than it has been before. And also, speaking about research, I think one of the real game changers, one of the European initiatives which really can create something new is the European Health Data Space. So, as you know, the idea of the problem with data in Europe, that especially about the health data, is that it is not that we have different standards and protocols how to raise this data. The data from different member states or even different regions from the same member state is not interoperable, cannot be interchanged, and this is a major issue because we cannot utilize the full potential of the data that we have in Europe now. And this data, especially for research and innovation, is crucial. For instance, when we speak about rare diseases, that also includes some rare brain conditions, definitely where we cannot conduct phase 3 clinical trials, where we do not have enough patients, using real-world data, real-world evidence, and the existing data sets that we have on European level is crucial. But if we want to do that, if we want to really use this data much better than we can and utilize its potential much better than we have up until this point, we really need this European Health Data Space. So what is European Health Data Space about? So first, we have two dimensions. So one is the primary use of data, and the second one is the so-called secondary use of data. The primary use of data refers to use of data by healthcare professionals. That essentially means that all of our health data, our medical records, will be in this European electronic exchange format. And this electronic health records will be able to be accessed by any healthcare professionals that we come across with. Of course, this applies both within the EU member states, but also across borders. So, for instance, if I'm on a business trip in Brussels, or I'm taking a sabbatical, or I'm studying in Germany, etc., I have to go to see a doctor. They will be able to access in a very easy way my digitalized health data, which also, of course, includes the data on some chronic diseases, and of course also, for instance, on if I'm having certain brain disorder, some medical condition related to brain which needs to be treated, etc. So this essentially means that medical professionals across EU will be able to access data much faster, which means faster diagnostics, and which means much faster and more efficient treatment. Of course, what is important here is that we also use whatever we can to protect patients' privacy, to protect their data, especially when we speak about brain disorders. This can be very sensitive for patients and for their privacy. So we are also, the Parliament is really very, very adamant about is that patients can also restrict access to part of this data or all of this data to certain healthcare professionals, which means that, for instance, if I'm going to see a doctor for some other condition, they will not be able to see, if I don't want that, they will not be able to see if I have some brain disorder or mental health issue or something like that. And of course, so I think that it is very important to leave the patients the possibility to limit and restrict access to this data if they feel that this is important for their privacy and for them in general. So that's the primary use of data, but I think even more important when you speak about research and innovation is the so-called secondary use of data. So secondary use of data essentially is the use of data by other other parties than healthcare professionals. And the main idea is that the main purpose for which healthcare data through this European health data space can be used is for research and innovation, to develop new innovative medical treatments for healthcare conditions that patients are suffering from. So the whole idea is that those who want to conduct research will have to send a request to these new bodies that will be set up on national level, the so-called health data access bodies, to access the data. But before that is made, so all, for instance, healthcare providers like hospitals, etc., will have to create this so-called catalogs of data, so that those who want to conduct research, like universities, for instance, can know in advance where they can find useful data and then make requests to health data access bodies. And if health data access bodies allow these requests, allow the access for research, this access will be done in a secured environment only for very limited purposes for which request has been made. And of course, when we speak about this, it is very important to emphasize, and always emphasize again when I speak about health data space, is that this will only be used to access anonymized or pseudonymized data. So this cannot be used to identify individual patients or to get data from individual patients. I think that is essential, that is crucial, especially from the point of view of data protection and privacy protection. So we cannot allow that, for instance, that those who want to, that some companies or even universities, etc., can access big data from big numbers of patients, and that they can use this to identify individual patients. So the idea is to give the possibilities for research institutions to access big data sets across European Union. They will have all of these catalogs prepared in advance, and to access them in a secure environment only for this specific purpose of doing research to develop new medical technologies and treatments. Of course, what is also important for the European Parliament there is that the patients also have their say. And this is one big change that we propose to the Commission's proposal is the so-called opt-out mechanism. So our proposal is that those patients who do not want to be part of the systems, who do not want their data to be used for secondary purpose, even though it is anonymized, will be able to say no and to exit this system. We went for the opt-out mechanism because we believe that with an opt-out mechanism, we will be able to, on one side, give the patients the possibilities to choose, but on the other side, we'll still be left with enough data, representative data, that it can be useful. If we go for an opt-in or a consent-based system, whereby patient would have to give consent every single time when a data access request is made, they would just not have enough data. So this is why opt-out is important for us, but we believe that we cannot go further than that if we want to have enough data for this to be useful. So we are currently doing political negotiations within the Parliament about this proposal, and I hope that we'll be able to finish by July or September at the latest the political position of the Parliament, and then in the autumn to negotiate with the Council and have the final political agreement on this health data space by the end of this year. Because if we enter next year, that's the election year, everybody will be thinking about elections, getting re-elected, etc. So then I think everything will be left over to the next Parliament and the Commission. Of course, there are other initiatives which are very important. I mentioned the revision of the pharmaceutical legislation, but I don't have time to get into that. That's also something very important. The whole idea there is also to strengthen the incentives to develop really innovative medicines and treatments, not just reinventing something that we already have. And I think the overall approach that we provide very strong incentives for really innovative treatments and technologies is important. I think that some things can be improved in the proposal, but I think in general it's a good start. So to sum up, I think European Union can do a lot. So we can do a lot in terms of funding, in terms of providing data for research and innovation, funding in terms of investments into infrastructure, into equipment, into better working conditions for medical professionals. Also, one thing that I did not mention is the legal framework on cross-border healthcare. That's also very important, especially for patients who are suffering from rare brain disorders, for which they cannot get treatment within their own member state, which means that they have to go abroad to other member states to get treatment. There we also have European legal framework which makes this possible. that you go to other member state to get treatment funded by your health insurance, but this legal framework is very complicated, and I think that we can also do a lot on European level to make it simple and to make it much easier for patients to access these kinds of healthcare treatments. So even though European Union does not have primary competence to regulate healthcare and to organize healthcare in Europe, I think that by all of these regulatory and financial possibilities that I mentioned, that we can really do a lot, that we can really create an added value and have both and be much better both in research and innovation, but also in terms of treatment and health outcomes for individual patients suffering from brain disorders. And I think that this is something very important. Within the Parliament, with this interest group, with this rebranding and the new start for the interest group, I think we can do a lot to really bring stakeholders together. It's important to also involve media, because politicians have the strongest incentives to do something where media puts pressure on them. So I think that's also something very important. Unfortunately, most politicians only are looking from one election to the next, and media there are very important. So I think that also having stronger visibility in the media on this topic, and we can use this interest group to do that. We can really put additional pressure both on the Parliament but also the Commission to really change some things. We have the Europe's Beating Cancer strategy. We have the strategy on that. We are developing some strategy in other areas. We have this overall, let's say, strategy on non-communicable diseases. But I think that for major health conditions like brain disorders or cardiovascular diseases, we also need separate strategies, because we cannot put brain disorders, mental health, diabetes, cardiovascular health under the same heading. So there are big differences in terms of priorities. So I think that a more streamlined, more specific approach for certain areas like brain disorders is important. This is something that I will be strongly advocating for. So I think that really brain disorders should be a higher priority in the European institutions, and I will be working on achieving that and raising the availability of this topic. So thank you very much. I hope I didn't take up too much of your time. Thank you.
Thank you so much. It was a lot of information there, a lot to take away as well. And of course, I'm sure that beyond the elections, throughout the elections, we'll be moving towards trying to integrate all of those ideas together. So next up, please welcome to the stage Tony Marsden. He is the Secretary General of the European Academy of Neurology, EAN, and he's going to talk about the burden of neurological conditions and the need for action.
Thank you very much for the kind introduction, and it's a real pleasure to be here representing the European Academy of Neurology. And the bottom line, as I guess you've just heard really, is the burden of neurological diseases is high, and it's really important that we take action. I'm going to tell you a little bit about the European Academy of Neurology. So this is an overarching organisation representing 47 national societies, spanning from east over to Western Europe, with interdigitation, with multiple ministries of health, and we also have corresponding members. So countries, for example, from Northern Africa are also embedded into the organisation. So we represent the breadth of neurology, and the members of our society are largely neurologists from these countries, but we also have members who are scientists that are working with neurologists and others to try and help us better understand neurological conditions and how we treat them better, ranging from basic science, what is the biology of the disease, through to how do we have better functioning health systems to provide treatment for people with neurological conditions. And as an academy or a society representing those individuals, it has a number of areas of priority. So it has a large responsibility for helping with education of neurologists and scientists interested in neurological conditions, and it has a role in pulling together scientists to better understand the condition. It supports its members, and advocacy is key, and of course that's part of what we're involved with today. So a number of years ago, the Academy embarked upon a project to help us better understand the burden of neurological conditions in Europe, and there was a publication, the years are flying by, this is just before COVID, in one of the Lancet journals, summarising what we understood about the burden of neurological conditions across Europe. And it really highlights that the high burden of neurological conditions, for example, they represent the third most common cause of death and disability in European citizens. And of course, as our population grows older, we know that a number of those neurological conditions affect the elderly, so that this burden is likely to get larger as the years go by. Again, highlighting the real importance of us getting our act together across Europe to better understand and reduce the burden of those neurological conditions. So the slide here, I guess, gives some of the headline messages again. So, and you've heard it already, about a third of citizens in Europe are affected by a neurological condition. And what's really important to understand is that neurological conditions affect people across the life course. So neurological conditions affect newborns and young children, and can have a huge impact on their future life, their education, and their ability to be productive members of society as they get older. And of course, there are hidden costs of parents and carers looking after children affected by neurological conditions. Neurological conditions can affect people of working age, again, impacting on their ability to function as best as they can in society. And again, as we get older, as our brains degenerate, again, we have a higher number of neurological conditions. So it's just really important to understand that we have conditions which affect people across the life course, and they are a massive contributor to disability-adjusted life years. So they cause a lot of disability, and they cause a lot of death. And we need to understand that if we look at the neurological conditions in their entirety, they actually represent greater burden than diabetes, cancer, and cardiovascular diseases. So it's really important that we don't just think about particular conditions, but we think about the whole area of neurological conditions, and start thinking about the health of our nervous system, which we might put under an umbrella of brain health. And what's really important to understand is also that we shouldn't only be thinking about the direct costs, the cost of the health service in managing people with neurological conditions. We should think about the indirect costs, the loss of productivity, loss of employment, the cost incurred to carers, and they are also massive. So we need to think about, well, how do we invest? How do we improve the care and outcome for people with neurological conditions? And clearly that's going to require upfront investment in research and services if we're going to better meet this burden. And we heard earlier about variability across Europe, and we have massive variability in the way that services are provided and in the way that research is conducted. And it's highly likely that this burden will continue to increase as our population gets older. One of our challenges is the workforce in neurology, and this, I think, is also a kind of a marker of health inequalities, or the inequalities that we have across Europe. And the graph here is quite startling, I think. So we have some countries where we might have one neurologist per 100,000 or 100,000 population, and then other countries where we might have one neurologist per per 6 or 7,000 population. So even within Europe, we have massive disparities in terms of the workforce. And I think this is just one metric which highlights the massive inequalities that we have in the provision of healthcare for people with neurological conditions. And of course, we don't only need to invest in manpower, we need to invest in the systems that those individuals are working with. We need highly functioning healthcare systems that are well integrated. We can't have neurology in a silo. Neurology needs to be well interdigitated with other areas of healthcare. So we desperately need new paradigms. We don't only need more money, we desperately need more money and investment in healthcare for people with neurological conditions, but we need to use that money widely, and we need to be thinking about how do we change the way that we do things so that we can maximize the health and opportunities for people with neurological conditions. And one thing that we should be thinking about is brain health in its entirety. This is the health of our brains, the health of our nervous system. And if we can promote and create healthier brains and healthier nervous systems for our population, that should lead to reduced burden for people with neurological conditions, and it should lead to a happier population. If we can improve our brain health, we should reduce the prevalence of neurological conditions. We should reduce disability. So why do we need to have a brain health strategy? Well, I guess we've already told you this over the past 20 minutes or so. Sadly, there are relatively few breakthroughs or not insufficient breakthroughs in terms of treatment opportunities for people with neurological conditions. We desperately need to better understand the biology, what goes on in the brain and the nervous system, so that we can counteract that with effective treatments. We have insufficient workforce, and we also have massive disparities in terms of where that workforce is and how it's deployed. We have significantly less funding for neurological research than we should. We don't really understand the determinants of brain health. What is it that makes our brains healthy? We understand things like smoking, alcohol, obesity, but there are other things that we need to discover. You know, what is it that really causes diseases like Parkinson's disease, epilepsy, common conditions that affect many people in Europe? What is it that we can do to prevent those conditions actually happening in the first place and helping keep people's brains healthy? We also have a problem with awareness about neurological conditions, and we heard again earlier, we need to be acting more effectively with the media. We need good campaigns. We need to make sure that everyone is aware of neurological conditions, how they impact people, reduce stigma, and also encourage investment into research and health services. So the EAN, the European Academy of Neurology, has been embarking upon trying to get a brain health strategy organised. It's in the early phases of that, and clearly we'll be working with many stakeholders and partners who many of whom are represented in the room today. We need to be thinking about how do we preserve our brain health? What are the things that we can do as citizens that are going to reduce the risk of us developing a neurological condition? And that, of course, involves, again, smoking, alcohol consumption, getting exercise, pollution, lots of things that we know about, but there's lots that we need to discover about things that we don't yet know about to help us keep our brains healthy. And it's going to be really important the neurologists and neuroscientists kind of get out of their neurosilo and work more widely in the system. We're clearly going to have to work with public health, for example, if we're going to think about what are the preventive measures. You know, what is it that we can do to prevent people ever needing to come anywhere near someone like me who's a neurologist? What can we do to keep their nervous systems and brain healthy? And we clearly need a really good plan. We need a good comms. We need to be interacting with policymakers to get this all organised and up and running. So we have a number of planks to our strategy in place. We want to contribute to what is a growing global action in terms of brain health. We want to support national and international policy. We really want to bring people together to take forward the research, which is so vital if we're going to better understand our neurological conditions and treat them. We want to be promoting education so that people better understand neurological conditions. That's not only neurologists, but that's the wider public. And again, reducing stigma of many of our neurological conditions and misunderstandings. So in summary, the burden of neurological conditions is massive, and they come at substantial cost to both individuals and to wider society. And we really must do something about that. That's likely going to require upfront investment to recoup costs and to make our citizens more economically productive and everything much more cost efficient. And this will only get worse as time progresses, particularly with our aging population. So we really do need new paradigms. We don't only need more money, we need new ways of working. We've heard a little bit earlier about how we can harness the power of our healthcare data to provide new insights, and that there are lots of potential examples of new ways of working that are going to advance the health of our European citizens. We need a brain health strategy which brings multiple stakeholders together to work effectively to drive this forward, and we need that investment in science and education. Thank you very much for your attention.
Thank you so much, Tony. Well, you were still on stage, and I hopped up on stage because MEP Sokol dashed off stage before I could ask him any questions. I'm not allowing you the same chance and opportunity. But just coming back to some of the things that Minister Sokol said, policy making, it's one of your 5 pillars as well. And, you know, there was the mention of elections. So MEPs are having to develop policy through the elections to move across elections. What would you like them to think about when it comes to long-term policy making?
Well, we need to be in this for the long haul, and I think long-term policy making is definitely key there. And he's highlighted that much of this is devolved to individual nations, but it's key that we bring nations together under the European Union, and we need to think very, very clearly about how do we invest strategically in research. How do we have specific calls that are going to bring scientists together to tackle the really challenging problems that we have around neuroscience. But I would also say that it's also vital that we have investment in the workforce and in how that workforce is deployed. I actually think that our biggest opportunity to improve the quality of life of people with neurological conditions at this instant is to actually make sure that they all have access to technologies and treatments that we know work. And we have massive health inequalities across states and actually within states, whereby because of lack of organisation of healthcare services and lack of manpower, people aren't getting access to the treatments that they actually deserve. So we need investment in research, but we cannot just sit back and expect that that's going to be a magic bullet to improve the health of our nations. We must invest in those services and make sure that they are well coordinated and delivering high quality care to everybody in Europe. So organisation of services, but you also highlighted huge problems with the workforce and the lack of neurologists out there. So again, thinking about Europe and the workforce, and we saw graphs as well and the differences between countries. How can we increase the workforce? What's your call out to young people or older people transitioning careers? How can we increase the number of neurologists out there? Yes, and that's a kind of needs a multi-pronged approach. We need to make neurology attractive for a start, and neurology and neuroscience attractive to people that are coming through medical school, even medical students, or even pre-medical school. We need to be making neuroscience and neurology attractive so that we attract the best minds into clinical neurology. As well as we need to be creating that next generation of excellent clinicians, and part of that is going to be kind of investment in the science. And science attracts, and also in getting the industry alongside the kind of the buzz that industry can create around certain conditions as we're driving forward science. That is attractive to young minds. So it's really important that we create that environment that is good, provides excellent clinical services, and attracts people into neurology. But on top of that, we also need to expand training programs, so that there are countries where the numbers of trainees for certain conditions are limited, and clearly that makes no sense when we've got one neurologist per 100,000 in the population. We must have more sensible healthcare planning, manpower planning in many of our European countries.
And then just finally, I won't keep you here too long, don't worry. Another pillar, but perhaps one that's quicker. The two questions so far have really dealt with long-term thoughts, bringing up the researchers of the future, the doctors of the future, and also policy making. But communication, and MEP Sokol also spoke about this, the communication to us sitting in the room, to those watching online. What can we do today to help our brain health?
Okay, so I'm not quite sure what you're asking me there.
I'm asking about the communication, effectively, how can you, as a professor of neurology, communicate to those outside? How can MEP Sokol communicate to those outside beyond the neuro silos that you spoke about to make sure that the communication to people every day is effective?
Yeah, maybe I should be asking you that, but clearly we need a comprehensive communication plan. And again, what we don't want to create is a load of echo chambers. So we can't just have an echo chamber where we have neurologists talking to each other about this problem. It's really important that we engage widely with stakeholders, patients, charities, politicians, and we have to create the environments, create the opportunity for those individuals to get together. But we have to have messages which are simple and understood and tangible.
Lovely answer. Thank you so much. Thank you very much for your time as well. Thank you. And next to the stage, of course, we have Orla. You probably all know Orla Galvin. She is, of course, the Executive Director of EFNA.
Thank you so much, Lisa. So today I have a few take-home messages for those of you in the room who are seeing you here. I think you already know this. But for those of you online, there are millions of you who will hear brain health, and it might not resonate with you that this actually is a topic that includes you. So when we talk about brain health at EFNA, we talk about brain health for neurology, and we do face a number of challenges. We have a situation whereby, and I must apologise, the screen is showing slides that are a little bit out of sync. Neurological conditions, as we've heard, are underfunded, under-researched, under-resourced and stigmatised. A study by EFNA has shown that 92% of people living with a neurological condition feel affected by stigma, especially those who suffer from what we classify as invisible conditions. We've heard about silos, we've heard about inequity, and this is absolutely clear among our constituents. EFNA represents 20 pan-European neurological condition groups, and the difference that we see in each of these 20 groups from east to western Europe is vast. There's also a lack of clarity when it comes to understanding neurological conditions. There are a number of trends that we are aware of and a number of opportunities when it comes to advances in technology. We've heard about the EU health data space, and we're delighted that patient involvement has been progressing through this development. We've heard about the demographic changes. We're an ageing population, and as our global population and European population increases, the number of people affected by a neurological condition will increase as well. This adds to a growing cost to society, and we also have to remember that those living with neurological conditions are often affected by other comorbidities as well. So when it comes to the puzzle of neurological conditions, there is a huge number of obstacles, but there's also a huge number of opportunities. And One of the opportunities that I'd like to draw your attention to today is the marking of the 1-year anniversary of the adoption of the 10-year intersectoral global action plan on epilepsy and other neurological conditions. All of the EU countries have signed up to this, so in effect, your local governments have already decided that this is actually a really good idea. This is something that we should invest in. This is something that we should apply time to. And what this will aim to reduce is the stigma, impact and burden of neurological conditions. When it comes to the IGAP, it has several guiding principles. We've heard about neurology through the life course. We have heard that neurological conditions can affect those from birth. These are chronic conditions, and we need to invest to preserve education, to preserve the workforce, and preserve those of us who may want to look forward to a retirement. When it comes to the strategic objectives of the IGAP, we are really focusing at this stage on strategic objective 1 and 2. Strategic objective 1 and 2 aim to raise policy prioritization and strengthen the governance, and to provide effective, timely responses of treatment and care. When it comes to brain health, we need to embrace it. For us, brain health really means neurology and neurological conditions. This is coupled with the fact that many people living with a neurological condition also suffer with a mental health condition over time, and this is also impacted by our environment. This could be whether you live in a city or a town. It could depend whether you live in East or Western Europe. What's fantastic is that today and increasingly across Europe, we are united for brain health. We are united for neurology, bringing together patients, clinicians and researchers, asking local governments to unite on common ground. While, again, I must apologise, these slides are not ideal for giving a presentation, but if I could ask you to focus on the character on the right-hand side of your screen. This is Neuron Ned. Neuron Ned here is presenting brain health. You can see his brain and his nervous system presented here. It is to remind you that every single part of your body can be impacted by a neurological condition. So when you hear the term brain health, we don't just mean your brain. We are talking about your entire human form, head to toe. Neurology can impact all of this. A number of conditions are presented on your screen, and again, you or someone you know is likely to be impacted with one of these conditions. They by no means represent all of the neurological conditions that people in Europe face. However, it is important to remember that when you hear brain health, that these are the conditions that spring to mind. And I don't say this lightheartedly. On your screen you see Neuron Ned, but you don't see Neuron Norma. And the reason for that is that in addition to the stigma, discrimination and isolation that people living with neurological conditions face, those who present as female are often stereotyped, and this leads to a significant delay in accessing a diagnosis and later access to therapeutics and care. The first step is to address policy and governance and to raise policy prioritization. What European entities have already agreed is a good idea, and 75% of countries globally have said that it is a good idea that we should aim for 75% of our countries to have national policies and plans or strategies that support neurological conditions. And 100% of countries should have at least one awareness or advocacy programme for neurological conditions. To that end, it is absolutely critical that we pick up on the point when it comes to engaging with media, social media, mainstream media. When we think of anything that is positive for our health, where did we hear about that from? Did we have to go to a doctor to hear about that? Did we learn about it at school? Was it on the TV or on the radio? It is absolutely important that mainstream media picks up the messages that neurological conditions are of critical importance for our long-term health. We have spoken about the need to stop acting in silos, and we need clarity for success. And what we need is a clear ask for clear benefits and clear targets. And if you're confused A wise person once told me, you just have to remember to KISS, K-I-S-S. Keep it simple and straightforward. And an example of this that we had at a roundtable in Amsterdam earlier this month was an example from Ireland, whereby 38 neurological patient advocacy groups came together under the umbrella of a national neurological alliance. They united 4 different sectors of neurology, the 4 clinical leads, and they approached Parliament to ask for a plan to secure increased numbers of neurological nurses. So these different groups didn't know what condition would receive the nurses first or most quickly or how many, but they knew it was absolutely necessary that an increase in neurological nurses was needed to support the community. So when they presented with a clear ask and a clear benefit and a clear target, the government delivered. And now there is a plan for the implementation and the provision of a significant number of new neurological nurses in the country. Today, I'd like to remind you that we're here with thanks to our host, MEP Suckle, and the Brain Health and Neurological Conditions MEP Interest Group. The mandate of this group is to promote patient empowerment for increased engagement. And we've heard about this in a number of EU initiatives when it comes to the European health data space. And later we will have Julie, who will speak about the revised pharmaceutical legislation and many of the components where we will have patient engagement there. We also have the opportunity to engage with the patient community to generate real-world evidence and real-world data. And through this, and again through promoting through mainstream media, we have the opportunity to, again through the mandate of this MEP Interest Group, eradicate stigma, isolation and discrimination, and to ensure equitable access to treatment services and supports. And what patient communities can do is survey our several thousands of people who engage with us and engage on our surveys and who represent the millions of people across Europe. We have learned that actually 92% of people living with a neurological condition experience stigma. And last year we discovered that only 1 in 5 people living with a neurological condition have access to a therapeutic intervention that satisfactorily manages their condition. You've heard already today that 1 in 3 people will be affected by a neurological condition in their life course, and then only 1 of 5 of them can manage their condition satisfactorily. Note, I did not say cure, and these are chronic conditions for the most part when we talk about neurological conditions. This means that 80% of people do not manage their condition well. We know that this is in part due to a complete absence of therapeutics for many people. We know that there are treatments available, but we are not quite there yet when it comes to precision medicine. We do see some advances in this space. We see some advances in the multiple sclerosis space, for example, where we can have targeted and tailored therapeutics. We're recognizing that when it comes to the differences between the male and female form, that again, some therapeutics that are designed for men don't actually operate as effectively in women. And the final part is affordability. And we will be coming to our MEP Interest Group again later this year when it comes to patient involvement in HTA processes across Europe, because again, this inequity that we see across Europe is something that we really have to tackle, and we have an opportunity, particularly for the neurology community, to address this now. So I'd like to thank you all for your time. I'd like to thank the EAN for engaging with us. It's a good example where we see stakeholders uniting together to support and promote the needs of the population of Europe. And with that, I will thank you for your time, and I look forward to hearing from Julie.
Thank you, Orla. Thank you so much, and thank you, MEP Suckle, who has to leave for further engagements. Thank you very much for your time. Orla, just a couple of questions. I mean, you've mentioned so many things there as well. A word that comes up again and again is inequity. And I was very struck by the fact that, we know it already, that in the research, there isn't always the research done on females, for instance. So there's an equity there as well. How can that be tackled?
So something that we have done last year, and something that we're waiting on a response for, is we united with a number of patient advocacy groups and a number of healthcare groups to table a question to the FEM committee to actually specifically address that, to ask for a framework for the inclusion of females when it comes to research and to identify in those cases where it is, and to be fair, there are times where it's simply not possible, and that's okay, but there are many, many instances where it is possible and it should be completed and achieved. We've seen some advances in the mental health sector where we now have medicines that are labelled as having been tested in females to prove efficacy in females as well as males. So there is a precedent of things that can be done, and so we're looking forward to seeing that happen again for the broader spectrum of neurological conditions.
Thank you so much for all those details. And of course, that would affect their mental health, no doubt, as well. So wonderful, wonderful talk. Thank you, Orla, and for organising today's event. Thank you. Now, our next speaker is Julie Spony, who is the policy officer from the European Patients Forum, and she's going to talk about EU pharma legislation and the impact on patient access.
Hello everyone, I'm thrilled to be here today representing EPF, so the European Patients Forum. We are an umbrella organization of patient organizations across Europe and across disease. Our 79 members include a national coalition of patient organizations, but also disease-specific patient groups at the EU level. And we are proud to have EFNA as one of our members. And today I will be presenting you the EU pharmaceutical legislation and its revision and the impact on patient access, including on patients living with neurological conditions. But before I start, I would like to define what is access to medicines. We can define access to medicines according to 5 principles. The first one is availability. The medicine needs to be available in the market. The second principle is affordability. Neither patients or the healthcare systems should suffer from financial hardship as a result of seeking for treatment. A third principle is adequacy. The medicine should be safe, of high quality, and efficient. A fourth principle is appropriateness. The medicine should be appropriate to patients' needs. And the last but not least principle of access to medicines is accessibility. The medicine should be accessible through reachable channels without time or geographical barriers. Having said that, you understand how this revision is important for the patient community. Sorry, I'm too short. This is very important for the patient community because this is an opportunity to boost the development of medicines that better address unmet medical needs, but this is also an opportunity to foster patient access to medicines by addressing shortages or by improving access to generics and biosimilars. And last but not least, this is an opportunity to improve patient involvement in the regulation and the regulatory process, which ultimately contributes to better regulatory outcomes. You may imagine that the patient community has many interests in different parts of the legislation, but for today's presentation, I will focus on 3 areas of interest to improve patient access to medicines. The measures to increase patient access to medicines, including medicines addressing unmet medical needs, the measures to improve patient involvement in the regulatory life cycle of medicines, and thirdly, the measures to prevent medicine shortages. Let's start with the measures to improve patient access to medicines. A huge part of the debate in the EU bubble is around the regulatory protection of medicines. So what is it? Regulatory protection includes data protection, which means that companies cannot use the data from marketing authorization, and it also includes market exclusivity, which prevents generics and biosimilar of entering the market. Currently, the regulatory protection is 10 years, including 6 years of data protection and 8 years of market exclusivity, and it can go up to 11 years. And with a revision, the Commission is proposing to introduce modulated incentives to stimulate access to medicines, but also to stimulate the development of drugs in certain areas. The first proposition is to introduce 2 years of additional regulatory protection if a product is launched and supplied continuously in all member states. So this is obviously something that we very much welcome, but we think it should be accompanied by a mirror obligation for member states to respect the 180-day deadline for pricing and reimbursement processes, because otherwise it will be a risk of member states keeping it hostage. And last but not least, we would like to include information on planned market launch in the application file. Another incentive that we find in the revision is an incentive to address unmet medical needs. So this is a concept that we hear everywhere at the moment in the EU bubble, but what is it exactly and what is attached to that? So in the revision, the Commission is proposing to add 6 months of regulatory protection if a medicinal product addresses unmet medical needs. And the Commission is providing a definition of what an unmet medical need is. So according to this definition, an unmet medical need is a severely debilitating or life-threatening disease for which there is no treatment available, or if there is a treatment, there is still a high percentage of mortality and morbidity. And secondly, the medicine product will improve and reduce mortality. So as you can hear, there is a strong link between mortality and morbidity and unmet medical needs. While for the patient community, there are other criteria coming into play, such as the quality of life or the burden, the treatment burden. Because this is not the same thing to inject yourself 3 times a day or to take a pill. So that's why we would like patients to be involved in the definition of unmet medical needs, because they are the best place to know what are their unmet medical needs. And for this, we will call for the inclusion of other criteria in the definition, in the legislation, and we will propose some amendments. Another incentive that will impact patient access to medicine is the use of comparative clinical trial data. So as you can see on the screen, the Commission is proposing 6 months of additional regulatory protection if comparative clinical trial data are submitted. So not only it will impact the adequacy and appropriateness of medicines, but it will also has an impact on the affordability and accessibility of medicines, because comparative clinical trial data will help national authorities to assess the cost effectiveness of medicines. And one of the issues we've seen currently is that there is a delay between after the marketing authorization and the next steps in the patient journey, because the data and evidence requirements differ between the marketing authorization and the health technology assessment and payers process. So this is why we welcome this measure, and we also call for earlier wide dialogue between all stakeholders, including patient organizations, to align on the requirements, including on the trial design or on the patient group to be selected. Another incentive that will impact patient access to medicines is the incentive for repurposing existing medicines. The Commission is proposing 4 years of regulatory protection period for repurposed medicines. We hear a lot about innovative medicines, but what matters at the end of the day is to have access to your daily treatment, whether it's a new medicine or old repurposed medicines. And I will come to this a bit later, but we would like patient organizations to be able to submit an application for a new indication if they have generated sufficient evidence. But I will come back to this later. Then let's move on to another measure in the legislation that will impact patient access to medicines, which is the emphasis on antimicrobial resistance. You may be aware of this, but this is a growing threat, killing 35,000 people per year in Europe, and one to which patients with chronic conditions are particularly vulnerable to, because they spend more time in healthcare settings or they require antibiotics to undergo surgeries. The revision aims to boost the development of new antibiotics and antimicrobials by introducing transferable exclusivity vouchers. But what are those vouchers? So voucher is an additional year of regulatory protection and it will be awarded to a developer of a game-changing antimicrobials if it meets two conditions. The first one is that the developer can supply the antimicrobial in sufficient quantities in the EU. The second condition is that the developer will indicate all public funding received for the development and research of the antimicrobial. At EPF, we have some concerns regarding the effectiveness and potential cost of these vouchers on the public health systems. And we think that incentives should decouple sale revenues from sale volumes. This is why we propose to introduce two mechanisms. The first one is the annual revenue guarantee scheme, which is already piloted in the UK and in Sweden, and where patients have access to more antibiotics than in the rest of Europe. So this scheme means that EU member states will come together and agree on certain antibiotics to be paid annually to pharma industry. And in return, the pharma industry will guarantee the access to those antibiotics. So this is it for the access to antibiotics, but to boost the development of new antimicrobials, we would like to introduce a pay-or-play model. So what is it? A pay-or-play model means that pharmaceutical companies that don't have an antimicrobial in their portfolio will pay a proportionate share of their revenue to a fund that will finance the development of antimicrobials. And last but not least, when it comes to measures to improve patient access to medicines, I will talk to you about the measures to improve earlier entry of generics and biosimilars that are very important to the patient community because they are often cheaper alternatives. In case of partial treatment, it improves the access to medicines, and it's also more sustainable to healthcare systems. So as you can see on the screen, the Commission is proposing to reduce the standard regulatory protection period by 2 years. It is also proposing to cancel the so-called sunset clause. So this clause is saying that if a medicinal product is not placed within 3 years in a market, the marketing authorization will terminate. And this is something we would like to keep because this is a useful mechanism to avoid having medicinal products being placed on the market, marketing authorization being running without the medicinal product being placed on the market. And this is also allowing earlier entry of generics and biosimilars. Let's now turn to the measures to improve patient involvement in the regulatory life cycle of medicines. If you remember the definition I gave of access to medicines, access entails appropriateness and adequacy, both of which will be improved by patient involvement in the regulatory life cycle of medicines. This is why we were very pleased to see a stronger patient representation in the Pharmacovigilance Risk Assessment Committee and the Committee for Human Medicinal Products. Both are scientific committees of the EMA. As you may know, with the revision, the EMA will have a new structure, and only 2 scientific committees will be kept, the 2 that you see on the screen. And in both committees, patient representation will increase. We will now have 2 representatives in the PRAC instead of 1, and in the CHMP we will have 4 representatives instead of 0. So this is a great improvement, but we would like to see greater clarity on how and if patient organization will be represented in the other scientific working parties that will be set up by the CHMP. In addition to that, we would like to include a legal definition of patient organizations because so it is not overlooked. And last but not least, we would like to have a representative in the coordination group for mutual recognition and decentralized procedures. This is the group dealing with marketing authorization at national level. And currently, we don't have any representative, so we don't have a say on all national marketing authorization. The legislation is also improving and strengthening the role of patient organizations as data generators. As you may remember earlier, I said that We would like to see patient organization able to submit data for new therapeutic indications. That will be the case, but only to address an unmet medical need. And we would like to extend this possibility to all medicines. I'm coming now to the end of the measures that will impact patient access to medicines, including patients with neurological conditions, which are the measures to address medicine shortages. Medicine shortages is a crucial issue for the patient community because it can lead to death, errors, toxicities due to a substitute, and this leads to poor quality treatment. And this is a more and more alarming situation because we see growing evidence that medicine shortages are happening everywhere in Europe, more recently in Romania or in France. And the current legislation is barely tackling shortages. This is why we were very pleased to see that the revision is putting an emphasis on shortages. For today's presentation, I will only mention two main provisions. The first one is the critical list of medicine. The Commission foresees that the EMA will establish a list of critical medicines by the end of the year after the adoption of the legislation that will enable the EMA to monitor and coordinate EU-wide response in case of serious shortage. And for this measure, we would like to see a strong patient involvement in the development of this list, so to ensure that it meets patient needs. The second measure is that member states' competent authorities will have to publish information on actual shortages of medicines on a publicly accessible website. This is not a groundbreaking measure because it already exists in most EU countries except for Poland, Malta, and Luxembourg. But here we will do advocacy around two main points. Because in the current revision, patients have a limited role in reporting shortages. They may be consulted by competent authorities if necessary, but that's it. So that's why we will push for a system for patients and patient organizations to report shortages at national level. Because not only it will improve data management, data collection about shortages, but it will provide a greater understanding of the societal impact of shortages, thus improving the management of shortages. And in addition to this system, we would like to have a EU-wide database with information from both the national databases and information from the legislation on falsified medicines. So basically, this legislation on falsified medicines requires wholesalers, pharmacists, and hospitals to check the authenticity of medicines at each stage of the supply chain. So we have a huge piece of information on where each medicine is located in the supply chain, and this should be used to better manage shortages. So voilà, that was a broad overview of all the measures that will impact patient access in the revised EU pharmaceutical legislation. And if we can remember only one thing is that we really need to have patients engaged in the drafting and in the discussion with policymakers to ensure that patient perspective is reflected, because at the end of the day, this legislation should reflect the needs of those who will benefit from the medicines approved at EU level and at national level. Thank you.
Thank you so much. I've taken a different microphone, so hopefully it's going to be on soon. Sorry, I must. It's okay. You've got the microphone. Perfect. I actually wanted to open up the floor. You gave a very comprehensive talk there. Are there any questions from the audience? We have two questions. So if somebody could, thank you very much, Orla, take this microphone and just bring it to the two people. Sorry to give you a job. There's two hands that shot up. So a lady at the back, first of all. And if you could also state your name and the organisation.
Good morning, everybody. Hi, Julie. Nice to see you again. I'm quite interested in the essentials list, and I'm wondering if you're working with the World Health Organization, because our World ADHD Chairman, Dr. Stephen Ferrone's approached them and they refused to put our medication onto the essential list, and we need help. He's busy looking at more treatment plans at the moment to put that in, and I would like to know if you're involved with the WHO and how you can help us as a supporter maybe, or feed through the system with us as one voice. Thank you.
Hi, Chantal. No, it's not working. Yeah. Yeah. Hi, Chantal. Nice to see you again. And yes, thanks for your question. We are involved with WHO, but not on the shortages side. This is something we've been aware that they work on this list as well, and that many different patient organizations approach them to put the key and crucial treatment on the list, but we don't work on it at the moment, but this is definitely something we need to look at it, and I'm happy to have a discussion with you afterwards. And because it is also one of my main points here, we need to unite forces, because as you can see on the screen and as you may hear around, it's going to be a huge debated piece of legislation, and we need to unite to weight on the balance, basically. So happy to have a discussion afterwards.
Thank you. Another question.
Thank you. So thanks for this presentation, Julie. I want to acknowledge an excellent work you have done in distilling this very complex file into these kind of very clear points and recommendations and what's relevant to the patient community. Let's not forget that the legislation, the two texts are over 1,000 pages, and we talked earlier, you actually read it, and so I want to first appreciate the expertise you're bringing here. My question is around this, what we could call the kind of IP armamentarium that drug developers have. Sometimes I'm getting lost a bit in all these different regulatory protection schemes. You know, now we have different years floating, 6 years, 8 years, 10 years, 12 years of different ways that companies have exclusivity. We have data exclusivity, market exclusivity, patents, and so on. We speak about extending 6 to 8 years exclusivity, but then taking also back 2 years initially. But could you speak a little more to these different regulatory protection schemes, like again, data, exclusivity, market, and so on? How does it look now in terms of the duration and where we are heading with the new proposal? I hope I made myself clear. Thank you.
Very clear, and of course, so I will first distinguish patent and regulatory protection. So patent is not in the pharmaceutical legislation, so I will only focus on regulatory protection. We have two types of regulatory protection: data protection, which prevents other companies to use the data in the submission of a marketing authorization application. And the second type is market exclusivity, which prevents generics and biosimilars to enter the market. Now, in the current framework, we have 10 years of regulatory protection, 8 years of data protection, and 2 years of market exclusivity. I mean, it's 10 years, but it's 2 years after the data protection elapse. And it can go up to 11 years under certain conditions. And here I'm only talking about the general pharmaceutical legislation. I forgot to specify, but EPF is not disease specific, so I didn't focus on the rare and pediatric disease. But for rare and pediatric disease, you have another type of regulatory protection. But basically, for the general pharmaceutical legislation, you can have up to 11 years of regulatory protection. Now, with the revision, the regulatory protection will go up to 12 years. So this is actually an increase of the protection, but the baseline protection is decreasing. So it's going to be 8 years, 6 years of data protection, and 2 years of market exclusivity. And on top of that, companies will be able to benefit of additional periods of regulatory protection if, for instance, they launch in all member states, or if they use comparative trial clinical trial data, or if they launch a product addressing unmet medical needs. So what we need to remind ourselves is now it's 11 years maximum, and with a revision it will be 12 years, but it will be modulated incentives, modulated periods. I hope that makes sense. It's a bit technical, but happy to discuss this further if it's still a bit obscure.
Thank you, Julie. You've clearly done a lot of homework. Just opening up the floor to, I can see there's one more question for you, but also if you have any questions for our other speakers here, opening up the floor. We're a small group here. I know you're online as well, so I'm sorry you can't ask us questions, but for those here present.
Thank you for all the presentations. And what I didn't see in the presentations is the rehabilitation of people living with a neurological condition. And that's also very important for the patients, because the science about brain, they have done a lot of work, but there's also a lot of things they don't yet know, and then they can't do anything more for the patients. And at that moment, the rehabilitation can help. And what about rehabilitation for patients with a neurological condition?
Thank you. That's an excellent question, and I think Orla and Tony will come in on this one.
Is this, yeah, I can hear this microphone is working. So when we talk about access to services and supports, we include rehabilitation, habilitation and rehabilitation, because there are many in the paediatric community that will need habilitation. For example, for those who are affected by an ocular component, oftentimes babies don't know what direction to go because they don't know what way even is up. So habilitation is very important, rehabilitation is very important. What I would say is, before that step, in order for many people to access any type of treatment, therapeutic service, support, whether that's physiotherapy, whether that's rehabilitation of other forms, whether that's occupational therapy, the first step is accessing a diagnosis. And that is a real issue. We have people, about 2/3 of respondents to an EFNA survey last year reported that they had to attend at least 3 clinical sites, so 3 different clinical sites, many attending 5 or more. Often people were taking advantage of the fact that there is possibility to transport across Europe, and we had individuals responding that they were in 3 different countries trying to access a diagnosis in order to get to that next step of accessing services and supports. So please by no means think that habilitation and rehabilitation are not included in the efforts. When we talk about services and supports, we embed that as EFNA, we absolutely embed that in that conversation.
Tony, would you like to add?
Yeah, I can only echo that really. I'm sorry if rehabilitation didn't come out clearly in my talk. There was rehabilitation actually written on one of the slides, but I don't think I actually highlighted it, did I? But it's clearly vital, isn't it? At the moment, we don't have effective treatments to reverse injury to the nervous system, and it's really key that we have efficient and effective rehabilitation services to help people, and we're really going to need the rehabilitationists to help us with kind of repair, research around repair. And we shouldn't just assume that the bits of the nervous system aren't repairable. Hopefully there are solutions, and working with our rehabilitation teams is going to be key. So neuro rehabilitation is squarely in the centre, if that's not an oxymoron. Okay.
I think we have a further question from the centre of the room.
Thank you very much, Vincent Quedbeck from the European Brain Council. Thank you very much for the comprehensive presentations. And I just have one question with regards to the unmet medical needs. I mean, we come back very often to this concept, and I think that there are many perspectives to take into consideration. Of course, the patient, the caregiver, the clinician perspective, the industry, the HTA also perspective. So I think it would be crucial to have, because this is in a way a measurement criteria. So how would you harmonize this, taking into consideration the life course, and also the care trajectory, the care pathway. When we talk about unmet medical needs, sometimes it's just access to diagnosis and so forth, but sometimes it's actually all along the care pathway, and sometimes it's not always taken into consideration.
Shall I?
Julie and Tony, whichever first.
Is it working? Yeah. Oh, thank you for your question. Very good question, and this is actually what I try to underline in my presentation, that unmet medical need is not only about mortality and morbidity, and of course other criteria come into play, but also in the care pathway. Now, when it comes to how to embed that in the legislation and how to harmonize that, this is a very good question, and I know different stakeholders wanted to not have a definition in the legislation because it will be too prescriptive in a way, and they would prefer to have guidelines. The EMA is going to develop guidelines, but the guidelines may not be drafted with patient groups, which is an issue, and this is something we will advocate for. Now, when it comes to the practicality of inside the legislation, in the coming months with our membership, we will sit down together and define a set of criteria that we would like to see in the definition, but to leave it open. So it's not going to exclude different patient population.
Tony?
I think it's become, hopefully it was clear during the presentations that the unmet need is massive, and yet we don't necessarily completely understand it. So we need to do some work to better understand what are the domains where the needs are unmet. And we certainly shouldn't be reductionist about that. We shouldn't just think this is about access to medications, about access to diagnosis, but it covers the whole public and patient trajectory through a very kind of medical course through to being at risk, having a diagnosis, and having treatment for what is often a long-term condition. But we have the wider societal unmet needs. Hopefully, we're try to illustrate that. Thinking about the indirect costs, the unmet needs of carers, unmet needs in education, employment. How do we maximize people's opportunities in their education, their relationships, their ability to function in society? So the unmet need is massive. We need to better understand it, and we need to all work together to plan how we address those unmet needs and get them resourced and get the manpower and woman power, etc., in place to help address those needs. So it's not trivial. It's massive, and I think we're just really at an early stage in that journey. We should be further ahead, but we are where we are, and we need to get on with it.
Thank you. I think we have one final question from the back of the room, and then we'll move on.
So I didn't introduce myself. I'm Chantal Fauché from ADHD Europe. I've been following the Book of Evidence, and I was very happy to hear all of it about the stigma and discrimination, the patient engagement, and the empowerment, and especially the timeless access to diagnosis and treatment. So my question is, from hearing from Orla that we should get more vocal on local level. So my question is, how do we see the list that's going on in EU level so we can roll it out to our national organisations and get them working with us, because we really need to start doing this now before the mandate finishes and the next project starts.
So can I ask you to clarify to see what list?
You were mentioning raising awareness as a global thing, and we should all start getting vocal on local level, and we should be asking the same thing. I was listening in the car and I was writing notes while driving.
Not driving, obviously.
Well, it's safe.
While it was safe to do so. So the example I gave was an Irish example, and the primary low-hanging fruit will be different in every country. You will have national neurological societies, you will have national brain councils, you will have cohorts of patient organisations. And what needs to be done to have the quickest and most effective deliverable on an ask is for all of those entities to come together on common ground. So it involves local groups engaging and sitting down with each other to find out what is that common ground. You need to take your own jersey off and work as a team. And when we see that happen, we do see parliaments engaging, we do see funding being ring-fenced, and this is something that can be done time and time again. We talk about the Global Action Plan low-hanging fruits being strategic objective 1 and 2, in particular strategic objective 1, because it is, I won't say it's easy, but it is perhaps easier than some of the other asks for people to unite on common ground around awareness campaigns. We, as EFNA, will be hosting a workshop towards the end of this year where we showcase some of examples around strategies towards developing national neurological plans and national brain health plans. And we will be launching a toolkit to support groups that want to act as national neurological alliances with a specific emphasis on current policy hooks, and the IGAP is one of those. So excellent question, Chantal. Thank you so much.
Thank you all so much. And we now welcome Russell Patton for the concluding remarks. He's the Vice President of EFNA.
Good morning, ladies and gentlemen. I think I was going to apply the KISS principle, keep it very simple. I think my first message is obviously first to the panelists. Thank you very much for joining us and for sharing your wisdom and your passion. Thank you for the audience here and obviously the many hundreds who are beaming in to listen to us. Sorry we can't get more questions from the audience. I always think more question time is very valuable because it really does home in on some of the key issues. Obviously this is a joint effort with EN. So Tony, thank you very much for coming all the way from Liverpool, and Orla, who represents EFNA, but also to EPF, thank you very much, a very important organisation. And I think that the three organisations together demonstrate that we as a community of patients and neurologists need to work closely together. That's the first message. We cannot work separately. Secondly is we have to work with the decision makers. And I have to say, I love Tomislav. He is a fantastic member of the European Parliament. I really hope he gets re-elected. And I think he underestimated the power of the European Parliament. And he focused on healthcare as a national competence. Per treaty, it is correct. But actually what Europe or the EU has done marvellously well, and in particular the European Parliament, is bring in health through the back door. It was first with tobacco and then the anti-tobacco movement and then Cancer Against Europe. We must not, as patient groups, neurologists, think that just because the EU per se can't do health, that they can only do sort of bringing a best practice. Excuse my French, it's bullshit. We need to move forward and push the European Parliament, its next mandate, to do more. And there are discussions that health should become a prerogative, a treaty power of the European Union. So I will be looking to our colleagues at EPF to push that message forward. When you look at the pharmaceutical legislation, I suddenly thought, gosh, that's not EU competence, but here's the EU reviewing a piece of legislation, 19 years old, which basically is the machinery behind how health operates in Europe. And we are able, slowly but surely, to have an impact, getting not only as a patient organisation there, but to actually concretely come up with proposals for better reglementation or regulation. So absolutely key. I loved the get vocal, get local, and I think that's critical. often people ask us, well, where do we lobby? Where do we talk to people? In Brussels, in the member states, WHO, it's all of them. But at the end of the day, it's a sort of bottom up and top down. You know, we have to really do both at the local, national, regional, European and international level. And if you think about it for a moment, we wouldn't be here without what the WHO did. Their Epilepsy and Neurological Action Plan forced, in effect, the European Union, 27 countries of which are members of the WHO, to actually start to look at neurology through their NCD program. They're a long way off, very long way off. But you see the domino effect of the top level doing that and vice versa. So I think we have to remember those different levels: local, regional, national, European and international. And as Orla said, this adoption of the 10-year intersectoral global action plan on epilepsy and other neurological disorders, that must have been a politician invented that terminology, is basically the framework upon which we can work for the years to come. I think, Tony, you said we're on a long journey. We're on a 20, 30, 40, 50-year journey. And as I represent, for example, the Parkinson's community, I keep telling them that we are trying to break open Pandora's box. But decision makers, and they're the crux of the matter, and they're the ones we've got to break. But break not in criticizing them, but in working with them and calling on them, the powers that they have to do better for consumers and citizens. And patients are citizens, and so politicians will listen to us. And there's often references to how much is being done on cardiovascular diseases, on cancer. So why are they not doing it in neurology, neurological diseases? Because 1 in 3 of us will suffer from that disease. I'll leave you with that statistic because I think it speaks very strongly. So without further ado, I would like to say, obviously, both to EFNA and EN and to our representatives here, Tony, thank you very much for joining us and the support of EPF. Thank you, Julie, for the moderation. Very, very well done. Thank you. And obviously to yourselves, and please join us again at many more webinars that we will be hosting. So on that note, I close the session. And for those who are here, you can still abuse of our coffee, hot chocolate and croissants. So thank you very much and have a very good day. Thank you.